Shilpa ma'am.
Yes.
Hello. Hello.
Yes, tell me.
Ma'am, let the screen there be for around 30 seconds. Then we will go for the video, ma'am.
Yes, sure.
Okay. Once it starts. So I need not to do anything, right? You will be handling it, right?
No.
Okay.
Yes.
Fine. Shall we go in 1 minute, ma'am?
Yes, everything is ready.
Daniel, shall we?
Yeah, I'm ready when you are.
Okay, so we'll go on air. Ma'am, my audio is clear, right?
Yes. Yes, you can start.
Okay. Welcome to the fourth and the last day of international webinar series on pandemic informatics and intendance. Delegates, please note, put your queries in the chat box. Your queries will be answered at the end of the session. Nurses across the world are risking their lives to care for the patients with novel coronavirus disease. Their hard work can be physically, mentally, and emotionally taxing. If you ask a nurse, aren't you tired? She will say, I'm not afraid, I am born to do this. This is an unprecedented situation which we are living and working through. Since the COVID-19 pandemic going out of the control, the need for deinstitutionalized nursing care is on high demand. To discuss the possibilities and challenges in deinstitutionalized nursing care for COVID-19, we have with us today Mrs. Danielle Didick. Mrs. Danielle Didick has graduated in nursing in 2009 from Regina, Saskatchewan, Canada. She worked at Pasqua Hospital in internal medicine and oncology for 4.5 years before moving to rural Saskatchewan. She worked for 5 years in the rural hospital in emergency room and acute care in Biga. Currently, she works as clinical nurse educator with an emergency room focus and a rural clinical nurse educator. Her service covers 2 emergency room facilities, 4 long-term care facilities, and 3 home care sites. We are very much proud to have you with us today. I'm honored to welcome Mrs. Danielle Didick to our webinar series. Now, the session is all yours, Mrs. Danielle. You may go ahead.
Thank you. I'm just gonna share my screen so you guys can see my PowerPoint. Now it's very basic. It's mostly so that I have an outline to follow than anything. So today we're gonna talk about deinstitutionalized nursing care in Canada. I'm gonna start with just a basic information about Canada and the way we're set up here. Come on. So Canada, we're a very large country with a very small population. We have only 37 million people as compared to your 1.1 billion people. Saskatchewan, which is where I work, in this yellow area here where it says Kindersley, that is the area in which I work, and I cover about, I don't know, about a quarter to a half of that area. We only have just over 1 million people here. So when we start talking about our COVID numbers, our numbers are probably going to seem very, very low compared to what your numbers are at. But that, like, it's all relative in the provincial size, right? So this is our statistics. I took these on the 27th of July. So right now we have 597 cases. So an approximate of 496 cases over the last 7 days. Our active cases are 3,611 mild and 225 serious or critical cases. So that are in our ICUs, and that's across the country. We've had almost 9,000 deaths, with a 99,000 resolved. So our resolve is quite high compared to our active. So in that way, we're doing quite well. I could not find an R naught statistic for Canada as a country, but I do have one for Saskatchewan. So in Saskatchewan, as of the 27th, we had 1,209 cases, and we're increasing about 35 a day. Although in the last couple of days, these numbers have snowballed quite a bit. We're averaging higher in the 50s and 60s every day. Right now, we have 307 active cases, 14 in hospital, 4 of those are ICU. And our hospitals at present run at capacity. So even a few in our acute tertiary sites are causing us problems. We've only had 16 deaths. I believe that's increased to 18 today. And we've resolved 886. On the 27th, our R-naught for Saskatchewan was 2.94. That has almost doubled. We're about 4.5 now. Right now, we're considered Canada's hotspot. We have the highest per capita infection rates per day. We've had a few issues over the last, I don't know, about 2 weeks now, where we're seeing huge increases in our numbers. The beginning of the pandemic, we did extremely well. Saw very few cases here, and now that seems to have kind of gotten out of control. So we are trying harder than ever to try and get this under control because our hospitals won't cope for very long. So this is what Saskatchewan has done to fight COVID-19. So we closed our international border. It's to the US as of, it's probably closed in the middle of March and remains closed. Right now it is until I think the 21st of August. So only essential travel is allowed to cross, so people moving grain or cattle or whatever. They are also allowed to cross because Alaska is in the northwestern part of North America. So if you're going across the border to up to Alaska, if you're an American going up there, they are allowed to cross, which has shown us some issues because they're lying, telling us they're going up to Alaska, and then they're staying in our vacation spots like Banff and Alberta. So that has caused us a little bit of a problem. We have some self-monitoring rules and self-isolation rules. So if you come back from international travel, if you're diagnosed with COVID or you're a close contact with COVID, which I'll get into how we determine that later. If you're considered one of those 3, then it is a mandatory isolation for 14 days. And these are finable offenses up to $2,000, as well as each business can be fined up to $10,000. At the start of the pandemic, we locked our province down. There was pretty much nothing open. They closed hairdressers. You could go to your essentials. So you could go get groceries. That was about it. See a physician. We shut down our malls, shut down anything that was not considered essential service for survival. We did all of that so that we could prepare our healthcare system so that we were ready. We did an increase in education. We set up some rules. I'll go through that later as well about unions and stuff, so they had more access to nursing, and got everything ready. And then starting in the beginning of May, we slowly reopened our province over the course of like May till I think the last reopening was here in mid-July. So there was 4.5 steps. So step 1, 2, 3, 4, and 4.2. So as of right now, for the most part, our province is functioning as it was prior to the pandemic, except for large gatherings. So our biggest gathering you can have right now is about 150 people outside and 30 inside your home. Those are also finable if you break those rules. They are, and then our restrictions on our healthcare facilities, none of those will likely go until we are out of the pandemic, till there's a viable vaccine likely, or it decides to mutate itself out, which I don't think any of us really see happening at this point. So we are pretty much functioning life as normal here again. Our public health does aggressive contact tracing. That was the whole goal one of the goals anyways, when we shut down, was to get that all in place. They hired more, or moved people more into positions to follow contact tracing. And every day our provincial government, as well as Saskatchewan Health Authority, updates us. So they give us a public address. So they're at 2:30 every day on Facebook Live. They come on, they tell us what's going on in our province. They'll give us areas. So back on that first little map I showed you, they'll say Central, which is where I work. Today we had 11 cases and this many recovered. And they'll give that update for each one of those areas. So we have the far north, the north, Saskatoon, which is one of our major cities, the Central, so the east and west, and they're combined as one, which makes it a little more difficult because we don't really know where they are. And then the south and Regina. They give us numbers, location, if there's an outbreak. It doesn't take a whole lot for them to declare an outbreak. You need one person in a facility. So if, say, a nurse gets sick and they work in a long-term care facility, they'll deem that as an outbreak, shut the facility down, and it'll go complete into lockdown mode, meaning only staff are allowed in and out. And then in general public, I think they need 2 that are non-traceable is when they'll call an outbreak in a community. We haven't had too many outbreaks in our communities. Right now, where I live, we are considered an area of concern as our numbers are growing quite a bit quicker than the rest of the province because we have a lot of communal living here. And then the Saskatchewan Health Authority will put out tips and tricks, how to keep safe, things like washing your hands and avoiding, and it's just like a constant repetition of the same type of information on the best ways that you can keep safe and keep your loved ones safe. So Saskatchewan healthcare system. So we do staff self-monitoring every day. So we go into work in the morning, we have a form that we can fill out, or we can do it on an online app. And it asks you a series of questions, things like any of the COVID symptoms. Are you experiencing these? Are you not? Have you tested positive for COVID? Have you in the last 14 days been to one of those areas that are considered an area of concern, or been outside of Canada? If you say yes to any of those questions, you're just not allowed to work. You have to go home. And we have a OH&S line that we call, so an occupational health and safety line. You call that line and they direct you on what your next steps will be. We do, and then there's a couple more, non-close contact and all of that. And then if you say yes to those questions, you're still allowed to work, but you have to self-monitor. We also take our temperatures twice a day. We take our temperature when we get to work, and then we take it again when we leave. We do patient screening. So when they come in through the door, they are asked a series of questions as well. We don't turn anybody away if they trigger one of those questionnaires and are considered COVID. We just change our PPE and keep them safe and keep us safe. And that works the same in the community. If you have COVID and one of our home care nurses or public nurses are coming in, they will do the same type of a screening, ask all those questions, and then they use the appropriate PPE. Because we're in an alerted area right now, we are wearing pretty much general PPE for everybody, which includes goggles or a face mask, mostly face masks, just plain surgical masks, and then gowns and gloves. We also have different designations for each of our hospitals. So we have an alternate level of care. So when we hit surge capacity, which to hit surge capacity, you need so many people in hospital in our tertiary, so Regina and Saskatoon, but you also need so many cases in your demographic. Then we'll switch over into the surge plan, which is alternate level of care. So then we shut down our acute and our emergency in those facilities to protect our long-term care sites because our facilities, a good chunk of them are both. They'll have a long-term care and acute care ER in our rural communities. They have COVID sites and they have clean sites and they have intubation sites. We're trying not to intubate in our rural areas just because it's such a high risk procedure. If we drop all our nurses, then we don't have nurses to care, right? Or physicians. We do regular education for staff on COVID and safe COVID practices. My entire job revolves around that. I educate public health, I educate home care, I educate acute care nursing. The only staff that I'm not really involved with right now is our long-term care nursing because I'm not allowed in those facilities anymore. They are starting to cohort us, so you can only work in one facility, or you can only work in home care, or you can only work in public health. You can't work in multiple, which makes a big barrier for us because lots of staff work in multiple areas. Every day at lunchtime, we get an email update that explains what COVID is doing in our province and what we need to do to stay safe. They also outline a bunch of mental health because I'm sure, as you guys know, it is a very stressful time right now. And we want to support our staff as much as possible. So this way, they've made like a special intake line just for medical people. They developed 2 field hospitals. So we have 250 bed field hospitals ready to go, one in Saskatoon and one in Regina. They are stocked and ready. We just need to hit that surge capacity and need those beds, and then that will open. I'm not sure how your guys' hospital runs, but ours run at capacity a lot of the time, especially our tertiary sites. So with the increase in COVID, although right now such a low number, we really don't have a lot of bed space. I'm not sure how long it'll take us or if we will ever end up using our field hospitals, but they are ready for us if we do happen to need to go into that. And then we have the continuous masking policy. So all nursing, housekeeping, maintenance men, those types of individuals, dietary, everybody who works in our facility wears a mask for their entire shift, as well as when they're going into patient homes. And then the patient wears masks when they come into our facility. So I talked about the screening. So the risk assessment, we use those screening tools. That is about the only way that we can determine a risk. Then we also have an exposure algorithm. So this came into play more earlier in the pandemic because we were using less precautions to start with, and now we're using PPE so much. But it is happening where we are having to follow this algorithm. And in this algorithm, it walks you through what your contact level is, whether you're a high risk or a low risk, based on different factors. So were you wearing a mask? Was the patient wearing a mask? Were you wearing goggles? Were you wearing your PPE? How long were you in the room? Because they don't consider us a contact till we've been in the room for 15 minutes within 1.5 meters of the patient. So if you walk into the room, grab something and walk out, you're not considered a contact of that patient unless you're in there long enough. And so we use that to determine whether or not staff can work. So if they're considered a high risk, then they're not allowed to work. Yeah, basically. But it's a two-sided, it's a good algorithm. So now we're going to talk about managing patients at home, which I think is why we're here. So 811, 911 is our emergency line. 811 is our health line. In 811, if you call that number, you will speak to an RN. That RN will ask you a series of questions. They will then refer you off for testing. Right now in Saskatchewan, you can get a test without symptoms. All you have to do is call and request, and they will set you up an appointment at one of our testing sites. In Saskatchewan, we have multiple testing sites. In my area alone, we have 3. One of ours has a gene expert machine, so they can get real-time results. So you swab them and you have results within 30 minutes. It is also our intubation site. That's why we did it that way, was so staff knew what they were walking into when they were going into intubate. We have some of our testing sites are also assessment sites. So our physicians are not seeing patients in person, not very often. We're trying to keep them safe. A lot of our physicians are older in rural and therefore quite a bit higher risk than most, right? So we're trying to keep our physicians out of our facilities as much as we can and only bring them in when we need them. And they're not seeing patients in their clinics. So we are using things like PECSIP and virtual care, like tablets and stuff. So the patients can see the doctor and the doctor can see the patients. They can inspect rashes or listen to a cough or whatever it is that they need to do. So that physician can then refer the patient on to an assessment site. They go online, they fill out this form, and then the patient will see a doctor at the assessment site within 24 to 48 hours. If they are too critically ill and they can't wait the time frame that they are asking of them, then that's when they'll send them up to the ER usually. They'll send them up to us, we'll assess and treat and send home or admit depending on what's going on. We do lots of education. So every patient that is swabbed is sent home with a pamphlet. In this pamphlet, there is information on self-isolation, self-monitoring, coping with self-isolation, what COVID is and how to stop the spread of it. And then we educate them as much as we can. We talk to them about, you know, how to keep your fever under control and those types of things. If they are started on Ventolin or Pulmicort or Nebs inhalers or whatever to treat the respiratory issues that they're having, they can get medication deliveries. All our pharmacies across the province will deliver whatever you need to your doorstep free of charge. And they will also do the education with you over the phone, give you pamphlets, handouts, those types of things if you've never used a inhaler before, to try and keep people at home as much as possible. Same with the grocery deliveries. They all are in our small town anyways, and our rural areas, all our grocery stores will deliver. In my town, I live in Biggar, so in Biggar, there's also like a committee of young people that will go out and do your grocery shopping for you and deliver it to your door as well. So that's nice, even for, say, our elderly that don't want to go out because the risk to them is quite high if they contract the COVID. So those are our main ways that we try to keep people at home as much as humanly possible. We also ask that prior to coming to our facilities that we have them phone us so that we're prepared to receive them. Like I said, we will never turn anybody away. We just need to be ready for them to make sure that they are as safe as they can be, as well as us. So home care, so they do in-house support. So, and that can be anything from, you know, managing Coban dressings on their legs, IV antibiotics, in-house teaching. If they aren't getting enough education through the pharmacy and they can't figure out how to work their inhaler properly, or they're really struggling, our home care will go in and do that education and help them figure everything out. And they also do in-house testing. So instead of, our elderly or people with decreased mobility, home care will go into their homes and test them instead of having them come out into the community for ease for the patient, because we'd rather them be tested than not, right? Because the more we know, the better chance we have of fighting, right? If we're left in the dark, then we won't succeed. Public health, so their big goal is contact tracing. They also do in-house testing. With their in-house testing though, they'll go into a community. So we had a big an outbreak up in La Loche, which is up north. So it's an isolated community. Our public health went in and they went door to door and tested the entire community of about 2,500 people or so to see how much the spread had been, and then do the education to go with it and the isolation and all of that. They do the contact tracing. They'll sit down with you on the phone, find out where you've been, who you've been in contact with, how long you were in those facilities or buildings or wherever you were, in that time frame. Once they gather all that information out, then they go out to all those people that they saw and they talk to them, and then they test all of them as well, so that we can hopefully follow the spread of the virus. We also put out alerts on, if Mr. Smith went to Walmart and to Sobeys, which are grocery stores in town, in Saskatoon, and they were there for 2 hours at each facility, they can't actually contact trace that, because we don't know who else was in that building at the same time. So then they'll put out public health alerts and give the public a time frame. If you were in this grocery store in this town at this time, you're considered a non-close contact, so you are to self-monitor, stay home as much as you can and monitor yourself for symptoms. If you develop symptoms, that's when we go back to that whole stretch of call 811, testing sites and all of that. They're really the unsung heroes. These are the guys, public health are the people that are going to help us fight this the most. They also do follow-up. So if we're considered a staff, so if a staff, one of our home care nurses, say, for example, was in a house that ended up coming back as a COVID positive, they will follow up with them every day. They get a phone call once a day. They find out their symptoms, find out what their symptoms are and how they've been feeling. And they'll do that for 14 days, because you have to be isolated for 14 days from the last exposure, as well as patients. So if we have patients that are, say, admitted to one of our small town hospitals, when we discharge them, they're discharged with a bunch of information, as well as follow up from public health. Then public health will touch base with them every day to make sure that they are following social isolation rules, that they are staying away, because we even want them to isolate from their families in their homes. So we make sure they follow all those rules and that they're healthy enough to stay at home, that they're not getting sicker, because as we all know, COVID you seem to get better, and then all of a sudden you get a lot worse real quick, right? So they are really the heart of all of this in Canada. They're our big guns. And these barriers, staffing levels. So our home care, for example, only has 3 nurses for a community that's about 70 kilometers squared. So that is a huge barrier for us. So we have in our, I spelled it wrong, in our province, it's called an LOU agreement. So this is an agreement between our provincial government and the Saskatchewan Union of Nurses. This allows our government to pretty much look at any one of us and say, you are moving to this facility to work, or you're going to go work out of this facility in home care. It gives them free run over where we are working and what we're doing. It's part of when our province called the state of emergency, this all builds into that. So at any time, if we end up in a big problem, say a month from now, I could get a phone call and I could have to move 7 hours away from my family. It is what it is. Our areas are quite widespread. So the town I live in is very small. There's only about 2,500 of us in our little community. The next nearest community is, I don't know, 35 kilometers-ish away, and everyone's like that. Then you have the farms and all of that in there as well. So travel, getting from place to place is difficult for us, right? I had a really hard time putting cultural diversity in here, because I think cultural diversity is what makes Canada great, but it is also a barrier to us in more ways than one. So you have the language barrier, especially people who are new to Canada that are not speaking English fluently, and a lot of us don't speak more than one language, unfortunately. But you also have the way people address disease is different in different cultures, right? So we're having problems with them letting us into their homes or into their communities to contact trace, or even just to help, because we'll go in and try to assess and help them cope with the issues they're having. In our community, we have a lot of communal living situations, and they really don't like medical people very much. So it has proven to be quite difficult. But again, you have to respect everybody else's wishes, but still try to help the better good. It has been frustrating, and I don't think any of us really have a big answer for any of this besides education. We try to educate. Our government is working with their leaders, those types of things, to try and expand that. We also have, like, so our Native Americans, they live in they're very close-knit families. They live in communal living situations as well. When one gets in there, it spreads fairly quickly just because they are very family-based and very close, and people have a hard time breaking that when that is just their culture and their traditions, right? Non-compliance is a big one. You know, patients refusing to wear masks when you come in, they're refusing to self-isolate, self-monitor, saying it's a hoax, saying it's a trick, saying it's a government political. We see a lot of that. I don't know about you guys there, but it has been a big issue here, that this is all fake, which we all know it isn't. And then fear. People are scared, so people are being ignorant to each other, for lack of a better word. They don't, are not respecting each other. They're not helping each other. There are some, I could tell you wonderful stories of people who are, but also stories of people who are just awful people. So that has been another, the biggest solution to all of this is education. The more we can educate and build rapport and do all of that, the better we're going to fare in the long run. Transportation. So if a patient gets sick at home, there's 3 options for transfer out. So Bigger, the community that I cover the most, we are about an hour and 20-minute drive from our town into the nearest trauma center. So personal vehicle, if they're well enough that they don't need oxygen and they're coping, they can go by personal vehicle. We also have emergency medical services, which is our EMS. So that transfer could happen one of 3 ways: just with the EMTs, which is our EMS staff, with an ACLS RN. So we have like specialty training in advanced cardiac life support, so we can give medications without doctors and stuff to treat en route, or they can go with a physician. We also have shock trauma air rescue service, which is STARS. So they are an air helicopter that will land anywhere in the province. All of our sites have designated landing areas, as well as they'll land on a highway or they'll land in a field because we're quite flat, right? So they'll land wherever they need to land to pick up the patients that they need to pick up. All of our EMS, like our ambulances, are all negative pressure based. So we are doing quite a bit of our treatment within their ambulances because it's safer. A lot of our facilities don't have negative pressure rooms. So anything like CPAP or intubation, we are trying to do in those environments versus inside our facilities. EMS and us, though, we fall under different categories, so we do run things a little bit differently. So protected code blue, I'm just going to talk, hopefully not too long, about this. So protected code blue, so unlike, okay, so it happens, EMS as well as home care may initiate a protected code blue. More so EMS, which is our community medicine, right? They will initiate a protected code blue in the community. If EMS does initiate that, they will not be brought to our facilities. The EMS will run it and take them to tertiary, so Saskatoon. Home care nursing, the only time they would initiate resuscitation is if they're actually in the home when it happens, right? We won't send them out to a code blue, only if they're actually there when it occurs. So this is something that happens mostly within our facilities. It is different than our normal policies and is become quite difficult for us to, not to stomach, it's different. In a code blue, we all run in head first. That is, I think, who we are as people, as we are there to help others, right? With this, it forces you to take a step back. You have to stop, you have to put your proper PPE on, concluding your N95. We can only do so much before we have an N95 on. So in Saskatchewan, we can do chest compressions and defibrillation, and that's about it. We're only allowed 3 people in a room at a time. So 1 physician, 1 EMT, and 1 RN, and that's it. And in a code, that is not very many people to run a code, right? Their mantra to us has been right from the beginning, there is no emergency in a pandemic. Because if we lose our nursing staff, if we lose our physicians, if we lose our EMTs, we are a very low number to begin with. It doesn't take a whole lot to make us non-functional anymore in any area in our little rural facilities out here. So a protected code blue is a lot slower run and has a lot more rules than a typical code blue, because in a typical code blue, you have multiple people, you each have a job, and away you go. These protected, you start at step 1, and until you keep doing step 1 until you have enough staff to move on to step 2, because you may be only one person in there for 5 or 10 minutes, and you might just be doing chest compressions and defibrillation for 5 or 10 minutes. We do have automated chest compressors. They're called, we have 2. There's an auto pulse or a Lucas, and that'll strap right under the chest. So that's the whole reason we want EMS in there, is nursing doesn't have access to that type of stuff, but our EMS does. So they'll bring that into the room with them and do chest compressions. That'll take somebody off the chest. So now we only have to manage airway, defibrillate, and put in lines. We use EasyIO. I'm not sure if you guys are familiar with that, but it goes directly into the bone. Functions exactly the same way as an IV. And you can't mess it up pretty much. You know, it's hard to get an IV when somebody's down. We don't do central lines, so we don't put in CVADs of any type in our rural sites. So this gives us central access or IV access quick, just within the bone. We do education on this. I run code blue practices with our home care, with our public health, with our ER nurses 2 to 3 times a week in every single facility. So I have 2 ERs. I run these. One site gets 2 a week, the next site gets 3, and then it flips. Every time I'm in a building, we run a code blue practice related to the protected code blue, or we do an airway management practice. And anybody who's in the building comes and we do it all together so that we're all on the same page, because it's not the same as our head first, right? So that's the end of my whole long spiel. I took all of this information. So if you, all those forms, everything that I was talking about on the government of Saskatchewan, there is a pandemic or COVID-19 stuff. There is copious and endless amounts of information on the way Canada and Saskatchewan is dealing with all of this. So a good chunk of the stuff I talked about come right off that website today. The Government of Canada is where I got your statistics from, and then the Saskatchewan Health Authority. It's the 2 of them together that made all the documents that we are seeing, or that we are using in our facilities. All right. Questions? I've talked a little fast. I'm short on time.
It's nothing matter, Daniel. It's fine. Your conversation was very good. And we have some questions here.
Yeah.
So let me read it out for you. It's a personal question for you. What are the challenges you faced and how did you overcome, especially in case of COVID pandemic? And any special benefits or staff intensives which is given for the staffs in Canada? Shall I make it clear?
Yeah, I'm trying to see if I can find it in the questions so I can read it.
Okay, we have already collected the questions, Daniel.
Okay, say that one more time.
Okay, what are the challenges you faced and how did you overcome?
So the challenges, like I said, our biggest challenge is staffing, without a doubt, and compliance. We have not yet overcome compliance. We don't, people just are ignoring what we say. But staffing, we are working on it. We are cross-trained our nurses between facilities, between job description. We are still working at one, but in the need that they need to move us, we have multiple experiences in different areas to try and overcome that barrier.
Okay, so we'll move on to the next question. The question is put forward by Chado Wangchuk. Any updates on use of hydroxychloroquine on COVID patients?
So in Canada right now, it is not a recommended treatment. I think because most things that I have read personally, they're not having consistent outcomes. And any document I've read, anything that I've looked at, some people do really well, but others don't. So I think because the way Canada works, like our FDA is quite stringent. Things have to be very well proven before our country will adopt new things like that. And as far as I know, I can't see that happening in the near future, to be honest, with any of the studies that have come out about it. Maybe down the road, once we've got COVID under control and they've got better studies done on it, maybe. But right now, I don't see that here anyways.
Okay, thank you. The next question by Vijesh. What are the precautionary measures taken by nurses during this COVID-19 and what the hospitals are providing specifically for the nurses?
So all of our nurses are provided with full PPE for every shift and multiple changes of that. We are offered, like I said, the mental health helplines and that type of stuff, regular breaks. We do daily huddles to talk through our issues and our problems and our stress, because COVID burnout is a thing. And I think something that a lot of nurses are facing worldwide right now. We are lucky in our rural areas. We are not dealing with it nearly as much as our tertiary is. So our home, except for lately, the last couple of weeks have not been good. We are not like have not been given anything like a financial stipend or anything like that. We're still working our normal hours and coming home. We try to, most of us nurses try to follow our rules as much as we possibly can. We stay home more. I've stayed home more in the last 6 months than I've probably ever had. Those types of things. Did I answer your question?
Yeah, I think special incentives should be given to the nurses, right? They are in the front line.
Yeah, I don't disagree with you, but
We will move on to the next question. The question is from Prabhu Shivaprasad. What about the psychological first aid for COVID-19 clients? Once they get diagnosed as having COVID-19, how you manage them psychologically?
so we have it's called intake, which was put in well before COVID. They're assessed when they go to that testing site. They are assessed by a nurse and they are given information on how to access mental health help. They're given resources, like I said, how to cope with self-isolation, and what to expect out of like symptoms they should expect to see over the coming days and those types of things. And then they also have access to we have mental health nurses and they all have different focuses. So some are mental health for children, some are mental health for women, some are mental health and addictions, because addictions is another big problem that I probably should have talked about. We've seen a lot of overdoses in our larger centers, and I'm pretty certain it's got to be related to the isolation and the fear of COVID, right? People are using a lot more drugs.
Okay, so the next question is from Suman Luthra. How many hours in your area the health workers can wear the PPE? That's a single time wear.
So it depends what area you work in. Me, for example, I wear one mask a day. I work 8-hour days, but I don't wear my mask continuously because I have an office. So if I'm in my office, I don't wear my mask. If I'm on the floor, I wear the same mask. It just comes with me and stays on I have a piece of paper that gets thrown out that just goes back and forth on that, which is probably not the most sanitary. But our floor nurses they wear one mask until it is either wet or they go for a break.
Okay.
We don't restrict their PPE. We just want them to use it until it's no longer safe to use again. We don't want them taking it on and off, those types of things. Or, this one really bothers me when they pull it under their chin, because then all this is dirty and then it's on your mask. It really bothers me. So we don't want people doing that. We'd rather you get rid of it, throw it out, have your coffee break or your smoke break or whatever it is that you're going to do for that time frame and get a clean mask when you return. So I can't really tell you in length of time that they're wearing it, because every nurse is different depending on the day, right? And right now we're hot here, like we're 32 degrees. So we're really hot. So our facilities are warmer, so that we're going through a little bit more masks too right now, right?
Okay, I think it's made clear. And the next question is from Mr. Prabhu. Whether CPR can be practiced on COVID-19 clients?
Can it be?
Whether CPR, pulmonary resuscitation, can be practiced on COVID-19 patients?
Yes.
Especially the focus is on the mouth-to-mouth breathing.
No, absolutely not. Okay, so I'll go into a little more detail on that. So our code blue practices, the bag valve mask, we don't even use that. So we don't use the bag valve mask and bag them. We put in an established tube. So we have ET tubes, like your basic endotracheal tube, but we also have King Airways. Is that something you guys have there? Esophageal, like that go down, two balloons on either end, and they go and they sit.
Yeah, we do have in our health system.
Don't have? Okay, so that's something nurses can put in. I can put that into somebody who's down instead of actually intubating them. So what it does is it blocks off the oropharynx. It also blocks off the esophagus and forces air in. That's our goal. We do not do mouth to mouth at all. We don't use any pocket masks at all. And we don't use bag valve mask unless they're under 16, because kids typically, when they go into cardiac arrest, it's because they went into respiratory arrest first, right? So you're not going to save them unless you work on their lungs. Adults are a bit different. So we are just doing high flow oxygen at 15 liters with a non-rebreather until we can establish a more definitive tube.
Okay, thanks for the answer. And the next question is from Professor Mary Elizabeth Pinto. What about the mortality rate in COVID patients, and who is more prone at Canada, means the vulnerability category of people? Then what are the major interventions taken?
So as far as I know, we're the same as the rest of the world right now. I guess the US is seeing more critical and younger right now, but the majority of our deaths have been, and our critical illness has been in the like greater than 60 category. We have seen a few younger. I think our youngest person in Saskatchewan that died was 20, but for the most part, they are quite a bit older. So our high risk categories still at this point are quite elderly for now. Looking at the states, that may change because they're seeing a lot more critical illness in your 20, 30 age group right now. But what was the second part of that question?
Second part was what are the major interventions you are taking
For our elderly?
to combat the mortality rate, to curtail the mortality rate?
Yeah, so
I think it's a collective effort, right?
Yeah, it is. And we're protecting our long-term care facilities to all ends. We aren't letting people in, which I have two opinions on that. Like we're locking them down so they can't see their family, which I find very heartbreaking because elderly want nothing more than their son or daughter or grandchildren, right? And we're effectively taking that away from them at the end of their lives, because with or without COVID, they are closer to their end of their life, right? We also have, like I said, those things like the groceries and the pharmacy and all those things so we can help facilitate our elders staying at home as much as possible so they're safer.
Okay, thanks for the reply. And the next question is from Anne Maria Dixon. How can we educate the old people more efficiently? Because many of the old people are suffering from age-related problems. The question is from the geriatric side, I guess.
Yeah. So actually, I'll show you this that I have here. I received this today, actually. It's out of Sweden. But we've got this form, and it breaks it down into pictures and words to try and make it clear. I think it's a great idea for our elders, for our children, for our intellectually, disabled. It will help. It helps break it down quite a bit. I think this is a great resource. I actually just sent it out today to my counterparts to see if we could try and figure out how to implement that in our area. But you're right, it is very hard when they don't understand what you're talking about or where you're coming from. Family involvement is something we really push, with our elders. If we need them to help us educate them, we do bring them in because they will respond to kids better, right? To their family better than they'll respond to us. But it is a problem.
Okay.
Yeah.
So we have a question from Dr. Sandeep. Actually, this is administrative related question and also which is debatable. Is Government of Canada is promoting herd immunity or try to improve immunity as yoga practice or herbs intake? That is alternative medicine are you seeking for?
I don't think that we are pushing herd immunity so much. Our goal is to keep the pandemic manageable until there is a vaccine in place. So our entire country wants to be able to treat the patients that we do see as effectively as possible without running into the issues where we're picking and choosing ventilators and picking and choosing who gets a bed and who doesn't get a bed, you know, things that have happened, is happening now in the States, right?
Okay.
We don't want to get to that point. Our goal is to keep it all at a manageable level until we have vaccine. Because herd immunity, the more I read about herd immunity, the more I don't know that that's going to be an effective method anyways, but that's my opinion.
Okay, fine. So we'll move on to the next question. What are the common measures need to be followed by all the people to prevent pandemic in the future? That's your personal opinion. They're asking for.
Well, I'm hoping that it just goes away like it did in 1918 and doesn't come back for 100 years, but who knows?
I think there is an interruption in the system. Okay, it's resumed. Okay,
Very
it's
good.
resumed. It's resumed.
No, you know, the world returned to semi-normal again after the pandemic in 1918, right? I'm hopeful we get
Even, yeah, we
that
can
we can
see
go
that
back to some
world
semblance
after
of a
COVID
normal
and before
life.
COVID.
Yeah, I'm just hoping we go back. But like and prior to the pandemic, I was not that crazy mom who forced her kids to hand sanitize after they touched every single thing. I do think germs are important for development of our immune systems, right? So this hand washing, forcing my kids to do this multiple times a day, me washing my hands at home multiple times a day has become a challenge for me. So I hope that goes back too.
Okay.
But I don't know. I'm hoping that we aren't going to need common measures.
Sure.
I'm hoping that we have resemblance of a normal life again.
Okay, so we'll move on to the next question, Daniel. The question is from Anjani Mathur. How are you managing with the side effects of medication used for COVID positive patients? Are these side effects interfering in patients' recovery? As per your
So
experience?
we're not really treating with anything besides Ventolin and Pulmicort in our areas. I'm not sure what they're actually doing in our major centers. So Ventolin and Pulmicort, as long as you don't have underlying, you know, cardiac arrhythmias and such, typically people tolerate very, very well. And then Tylenol and Advil, right? We are simply symptom managing at this point because there is really no proven. I did hear today they're talking about certain drugs that they're going to be bringing and we'll be using more in our tertiary sites, but I don't really know a whole lot about them, to be honest. I couldn't even tell you
Okay.
their names.
So what are the measures you are following or taking to avoid the stigma, the social stigma in the community?
So this is a huge thing where I live right now. People are being very mean because right now the group of individuals that are testing positive live in a communal setting and they're easy to identify. So they are seeing a lot of it. I think most of us are just trying to educate people that these people didn't go out. Nobody went out looking for COVID. Nobody wants COVID. It can go back where it came from, right? So it's been a lot of education. Our health region puts out a lot of education on treating people better. I would hope people in our community are standing up for each other and saying this is not okay because it's not appropriate. But it is. I keep comparing it to the AIDS epidemic in the 80s, that stigma that come along with that as well. Like it was awful and we are back there and I don't think we should be. But 40
Okay.
years later and 40 years smarter, this shouldn't be happening. People shouldn't be forced to live in fear like that. It's also hindering our ability to treat them because they're not coming forward, right?
Yeah, I think by this we have winded up the question and answer session. We are getting a lot of questions, but it sounds similar. So we are not putting you in trouble. And certain questions are coming from particularly some drugs. What are the
Drugs.
protocols you follow in using injection? Tozilo,
We
Mazep?
don't use that
Use it.
drug.
Okay, fine.
We use propofol. We're using propofol and to keep them sedated. I'm not even sure what that is. To me, that's got to be some type of biologic, is it not?
Okay, it's I think this according to the standard operating protocols you're following.
No, in our rule, like what I'm dealing with, we're not using, when they're critically ill, we don't keep them intubated where I work. They're sent to tertiary, so they are sent to Saskatoon or Regina into one of our ICUs. So we have an ICU, our main two are there, and then we also have probably about 4 or 5 other small ICUs that only have a couple of beds. We are not, we're not keeping them out in our rural areas at all. Like we don't even have a ventilator where I work. We have
Oh,
in our that little yellow spot that I showed you, there's one ventilator in that entire area. And that's our intubation site. That's the only ventilator we have.
so it's sure that all the frontline workers are in huge stress in combating COVID-19. Let's pray we
I
will overcome this pandemic as soon as possible.
I hope so. I've enough there. You oh,
Your voice
oh,
is
my internet.
breaking.
Becomes stable for
There was some interruptions in the streaming, I guess. Okay, now it's resumed. Okay, ma'am. Daniel, it was nice talking to you, and we got an immense amount of information in the perspective of COVID management in Canada.
not a problem. I enjoyed it.
Okay, we have enough questions coming on, but due to time constraints, we will wind up the session for time being, and we'll meet you
Okay.
in other sessions in the coming up times.
Sounds good. You have a great rest of your day. And good
Okay.
luck in your nursing careers, because I believe most of you are nursing students, and it's not going to
Yeah,
be the most pleasant coming out of school in a
majority of our
pandemic.
audience are nursing students.
Are they fourth year?
Yeah, they are fourth years, and all those classes are involved in the session.
So they're close to the end. Yeah, good luck. Coming out in a pandemic will not be easy, but I'm sure you guys can do it.
Sure, sure, sure. We must overcome.
Yes,
Okay. And very, very thanks for accepting our invitation and coming for the session.
not a problem.
Okay, we hope we will together overcome this pandemic and will come to the normalcy soon.
I agree.
Thanks, Daniel, for joining us.
Thank you. Have a good day.
Good day too. So, delegates, please note the next session will start shortly. Wait for a while and stay back.
Just say I have, yeah, I have answer. Just Tell her to check once. Yeah, yeah. It's on.
So, good morning, everyone. We are very much proud to present before you the next session, which would be a live demonstration. Myself, Mrs. Anusha, Assistant Professor of New Mangala College of Nursing. It's my pleasure to be the moderator for this session. The need for intensive care in the current pandemic is moving out of the threshold. The demand of expertise, skills, and knowledge is unconditionally increasing. The human resource alone cannot combat the intensive nursing care during the COVID-19. Highly sophisticated instruments, devices are on high demand with human resources in saving lives. There is a tireless collective effort from across the globe to design and develop life-saving appliances to reduce the COVID mortality. On this session, we, Mangala Group of Educational Institutions, is very much proud that our Managing Director, Dr. Ganapathi P, had come up with the working life-saving gear, which is ought to have a great impact to the health infrastructure and unable to curtail the mortality rate to a great extent. Today, we have with us an eminent personality, Dr. Ganapathi P, Senior Consultant, Anesthesiologist, Intensivist, Founder, and Managing Director of Mangala Hospital and Kidney Foundation. He completed his MBBS from Kasturba Medical College, Mangalore in 1985 and MD in anesthesiology in the year 1992 from Kasturba Medical College, Mangalore. He established Mangala Charitable Trust and Hemodialysis Department in 2000 for the purpose of alleviating human sufferings, eradication illiteracy, poverty, imparting Vedic and modern education with an opportunity for welfare and research program. With his hard work and determination, Mangala Nursing Home, which was established in the year 1988, has transformed to multi-speciality NABH pre-accredited healthcare institution in Mangalore. Alongside his efforts to manpower and reflected is constituting Mangala Group of Educational Institutions. Sir, it is indeed a special privilege to welcome you to this session. Over to you, sir. You may go ahead.
Sir,
Am I audible?
yes.
Yes, sir.
Yeah. A warm welcome to all the delegates who are taking part in the program. And today I will be basically explaining a little bit about NIV, why NIV, and various modes of NIV, and giving little more explanation on what is called a bubble helmet. So essentially, when we get a patient, COVID-19, who come with happy hypoxia, and we have to supplement oxygen to these patients. So what are the options that we have to supplement oxygen? We can start with the ward or room or ICU oxygen flow meter, the one which is like this, which is fixed onto a Schrader's quick coupler, a wall outlet. And then we have option to give 15 liters of oxygen in this humidification. So with 15 liters of flow, we can increase oxygen supply by increasing, say by rule of thumb calculation, every 1 liter of oxygen will increase FiO2, that is fractional concentration of inspired oxygen, by 4%. So we assume 21% to be room air oxygen. Then we keep on adding 4% to every liter that we supplement to the patient. So when you go to say 10 liters, we are adding 40% more. So patient will be getting something like 40 plus 21, 61% of inspired oxygen concentration. Of course, this will not take into account the physiological and anatomical dead space, especially the anatomical dead space. So we may not be giving that high, but definitely it increase the inspired concentration. So this is the entry level option that we have to give supplement oxygen. Next, what we have what we have to use, what are called the interfaces to the patient. There are various interfaces that can be used whenever we give oxygen to the patient. The commonly used one, this is called the non-rebreathing face mask, oxygen face mask. And this is what is called the rebreathing oxygen face mask. This, by the way, is a one-way valve here, adds on little bit of CPAP to the patient, continuous positive airway pressure, it adds to the patient. But please be sure that this valve is positioned in the right direction. Supposing patient is lying like this, you can't have the valve facing upwards like this. It has to be at 90 degrees to the ground so that the ball valve mechanism works properly. And this is a reservoir valve. Remember, to give minimum 8 liters of flow using this mask. Then what are the other options we have? Supposing once this wall mounted oxygen flow meters are inadequate to the patient to maintain adequate saturation in the patient, then we have other options. The entry level would be something like this. This is a BiPAP machine. By definition, BiPAP machine means it gives 2 levels of power to the patient. One is during inspiration and one is during expiration. Why do we give BiPAP? These machines may not, wall mounted oxygen outlets may not give adequate positive pressure unless you're using one of the CPAP rebreathing reservoir bag. Otherwise, it'll be just giving oxygen under normal pressure. So what happens in patients who have lung diseases, because of the normal pressure, the alveoli tend to collapse. We need minimum 5 centimeters water pressure to keep the alveoli open, and this pressure keeps on increasing as we give. We have patients who are in more respiratory distress, who have more pulmonary changes, more fluid accumulation in the lungs, and the density of the lung has increased. Now, once we have the CPAP machine, again, we need various interfaces to give oxygen to this machine. The CPAP machine works in a simple principle of giving continuous. This is BiPAP machine, gives intermittent pressure. This also has option to give CPAP. Now, considering the experience that we have gained, we have always found that BiPAP machines are not adequate enough to give relief to the patient when they are in severe respiratory distress. But of course, we can use them. And the best way to use this machine is you have the BiPAP machine, that is the outlet. You attach it to one humidification filter, HME filter, and to improve the oxygenation, to give extra oxygen, you attach the wall outlet through a pipe to the HME filter and connect it like this to the patient. And then using Venturi phenomena, oxygen will be drawn from the wall outlet and patient will get enhanced oxygen supply. So to use these machines, what are the options we have? We have masks like this. Now this is a rigid mask if you see. And if you see, this edge is very rigid. So using this mask continuously for 7 days, 8 days, 10 days will give rise to face decubitus ulcers. That is along the facial lines of the patient where this is exerting positive pressure because of the shear pressure applied to keep in place to achieve a non-leak fitting. It will give rise to pressure decubitus ulcer on the face of the patient. And also the aerosol generation becomes more whenever you use masks like this. Or if you look at this, this is a scented air cushioned mask. If you see, there is an air cushion here and we can increase or decrease. So this is typically a high volume, low pressure air cushion. This also can be used. Again, this also has its own disadvantage. So then what do we have? A modified version of the face mask, which we made ourselves, is something like this. This is an ordinary snorkeling mask, and we made connectors for this. Now, if you see, this is a single port connector which we have made, and it just fits in here tightly. There is a separate washer we give to prevent the leak. This can be connected to a continuous pressure generating device. It can be connected to BiPAP. It can be connected to a pressure support ventilation mode also. The connectors, essentially, we have made two types. We have one with double port and the other one with single port. The double port is whenever we use any oxygen device which is not a ventilator, in which case we have to use this. To the other end, we have to attach a filter, and you have to attach a variable mechanical filter. If this is a mechanical filter, and you can increase or reduce the pressure, which this gives what is called CPAP. But in CPAP, actually this is a PEEP valve, but by definition CPAP is PEEP applied during spontaneous respiration. So this is the second connector that we have made. The third device that we have is what I call the oxygen bubble hoods. Bubble hood is not a new concept. We have been using it from probably long time. In pediatric and neonatology, where we started using rigid bubble hoods for the first time. We had transparent rigid bubble hoods, which was kept on the baby's head end, and that was getting continuously humidified oxygen to adequate and increase oxygen concentration to the baby. Going onwards from there, from the year 1971 to 1991, a lot of innovative thinking went into it, and that is when they came up with this kind of transparent oxygen bubble helmets. If you see this helmet, this is the transparent hood part of the helmet. Ideally, this should be at least about 10 to 12 liters in capacity, a hood that is twice the total lung capacity of the patient. Excuse me. This will have multiple ports here. This helmet that I'm showing here has two ports. One is the inlet and one is the outlet. If you look at it, this is the inlet that is connected with the HME filter to maintain heat, humidification, and also reduce the noise level. Whenever you use a bubble helmet, there'll be a lot of noise. The noise level can go up to 100 dB. So to reduce that also, this is helpful. Apart from heat and moisture, it also helps reduce the noise level. Then we have the expiratory port. An expiratory port has invariably, you must put a HEPA filter or a wire filter and then connect it to a mechanical PEEP valve. This mechanical PEEP valve is absolutely essential, whether you use this bubble helmet with CPAP, we use it with high flow, or we use the pressure support ventilation, or use it with the BiPAP machine. Because this is one which acts as an anti-suffocating valve. If you don't do this with only one port, we'll have suffocation. So we have added on this, and we reduce the PEEP level to patient's comfort, and also to reduce the suffocation to the patient. That is one aspect of it. Whenever we have this HEPA filter or viral filter at the expiratory port of these bubble helmets, it reduces the viral load in the ICU drastically. So this is a great advantage and benefit to the healthcare professionals who are working in the ICU. There are a lot of advantages of this bubble helmet. It is transparent. Patient can communicate with the staff. He sees all the healthcare workers moving around. He can, whenever he has visitors, he can communicate to them. He can even read through the bubble helmet. From whatever newspaper, he can use his tab or laptop computer also. Now, how do we connect this? If you see the base of this bubble helmet, it has got a rubber. So we make a marking. So these two have to come to the front of the patient, and we make a marking here to suit to the head of the patient. We keep it slightly posterior so that there is space in the front. Once we do that, we connect it to the ventilator. This is the first option. I have my choice would always be use a bubble helmet with a pressure support device. switch it on. Okay, this is a dual limb circuit ventilator. If you see, you may also have single limb ventilators, which are the lower end of these lower end ventilators. You can use them also to connect it to the bubble hood. So this circuit is attached to the inspiratory limb. Please understand that in case you are using a humidifying chamber in the oxygen in a ventilator, please attach this filter before the inlet of the ventilator into the humidifying chamber. Supposing if this is the ventilator connection, you're using a humidification chamber so that you don't give just dry oxygen or dry ventilation to the patient. This is where we connect it. So at that level, we always attach a viral filter here, and we don't put a HME filter there, and we don't prefer putting it to the oxygen that is coming out of the ventilator if you're using a humidification chamber. Connect. No, here. Okay. Now, if you see, everything is in place. Now, these are the straps, because once we build up positive pressure in this, the bubble tends to go up, the hood tends to go up and down. To prevent that, we have the straps. These are nothing but the shoulder straps. What options you have in the ventilator? We have option to use straight away PSV itself. See, we have pressure support ventilation option. We can use that. This is the option we have. And if you see, I'm tightening the limb to prevent the mechanical PEEP valve, to prevent the leak. So now if you see, it is getting ventilated with straight away pressure support ventilation. I can see intermittently the bubble going up and down. So this is one option you have. The second option we have is to go to non-invasive ventilation modes in the ventilator. We have PSV, NIV, pressure support non-invasive, and I have validated it. Now if you see, again it works. We want some inspiratory effort for the patient, and then automatically it will deliver. If you see the bubble moving with my hand. So when you have this in place, you are rest assured there is no aerosol generation procedure that is happening onto the patient. Aerosol can be generated by the patient himself or by what is called medical aerosol generating procedures. So in this, the patient's aerosol generation becomes much less, and the ICU staff remain much safer. Other advantage, this can also be used for transport. Say you have a COVID positive patient, high infectivity rate, you are worried, patient has to go to CT scan, patient has to go to MRI, then you can easily use this and patients can be safe. If you see this, this is MRI, this can be made MRI compatible also, because there are MRI compatible connectors available for this bubble hood. Okay, third option, what do we have? We have oxygen. You go here, we have oxygen. We can set high flow oxygen in this machine. We have CPAP option. You can give only CPAP. Again, use the same bubble hood. Put it to high oxygen. This is CPAP, oxygen therapy. No, there is oxygen therapy option. Anyway, okay, all right. So this is advantage. So it can be used with the good ventilator, either dual limb or single limb, and this has multiple advantages. Most important being reduced supply of reduced delivery of viral load to the staff who are working. Then this helmet can also be used with, as I said earlier, even ordinary machines. Look at this. This is a BiPAP machine. So it just gets connected here, and patient continuously gets positive pressure, and again the expiratory gases are taken care of by reducing viral load by adding on this HEPA filter. Then we have here with us the third option is a high flow oxygen device. This also can be this is a high flow oxygen device, and we can go with this machine up to 60 liters flow, and we have control on CPAP and all respiratory rate. So many controls are there. So essentially this also gets connected to the same bubble hood, and then again the respiratory component of patients' effort can be reduced, and patients, what I found, patients are quite comfortable with this bubble hood. We can use it with an ordinary old generation CPAP machines. If you see, this is a mechanical blinder, and we connect the adjust the FiO2 levels, and we can again give up to 50 liters of flow. With that also this bubble helmet will work. Now coming back to the snorkeling mask. So if you see, I have a single limb connector, single port connector, and this gets easily connected onto the ventilator with the appropriate filters in place, and patient gets adequate oxygenation. I would like to say a few words about specific advantage of this kind of masks. If you see, this mask has a very soft silicon based rim here when compared to a rigid mask here. So this fixed onto the entire face of the patient, and patients are much more comfortable whenever you use a mask like this, and there is less chance of pressure changes that we see on the face when you use it for a long time. So this is the other advantage, and this is how to connect with a ventilator, or if you use this, you can easily connect it to CPAP machine. You can easily connect to CPAP machine, BiPAP machine. You can use it to high flow oxygen device as well. Regarding various advantages and what happened with the bubble helmet, what are the specific advantages, I don't think I'll be able to enumerate in detail, but definitely I found this to be a very useful device. Starting when, supposing you get a patient into the emergency room who is in respiratory distress, you don't know, you have to work him up to come to a diagnosis whether he is COVID-19 or he has got an ordinary ELE. So in which case, you can safely insert a bubble hood till the patient is walked up, and you come to a diagnosis with whatever investigation that you want to do from throat swab, RT-PCR, whatever. Until the patient is diagnosed, we can safely use these bubble hoods. Cross-contamination to other patients and to the healthcare professionals is reduced. Now, coming back to the last part of my talk, this bubble helmets or even this mask can be used even in the ward settings, can be used in room settings. Considering the present scenario with so many patients needing ICU care and reduced availability of ICU beds, we can use this with the turbine-based ventilator in the room of the patient. All that you need is one monitor, apart from probably a pulse oximeter. You require a turbine-based ventilator. You need bubble hood or one of the other interface, and can be used in room settings. This way, patients needing ICU, who really need ICU, you can reserve beds for those patients. Whoever can be managed in the room setting with the bubble hood or a snorkeling mask can be managed in the room only till such time that patient recover or really need ICU care. We always give 2-hour trial with a bubble hood. But please understand, this is not some kind of magic bullet to treat COVID-19. These are all various interfaces that we have. Patient to machine interface, what we call. So these interfaces can be, you can choose what interface you want depending on patient's condition and how they perform with each interface. I would go with a clinical trial of 1 or 2 hours of ventilation using a bubble hood, using either an IV setting or a pressure support setting in a ventilator or a high flow or a BiPAP or CPAP machine. Thank you. You have any questions? Please go ahead.
Thank you, sir, for your dynamic presentation. The innovative craft which you have designed and developed is much appreciated. It is indeed a great achievement. So, dear participant, please type your queries in the chat box. So, we have one question here. It was asked by Prabhu Shivaprasad. Whether hyperbaric oxygen therapy can be given to the patient with COVID-19.
Yeah, definitely hyperbaric oxygen therapy has a role in COVID-19 patient. You consider hyperbaric essentially means you're giving oxygen under high pressure. A borderline hyperbaric pressure effect can be achieved using a bubble helmet if you look at this, because this retains an interface between the patient and the ventilator of a high pressure chamber, because the pressure is built up in this, and we adjust the pressure according to patient's comfort using this mechanical PEEP valve. So considering the scenario that hyperbaric oxygen may not be available in every hospital, it is available only in designated centers. This will substitute it to some extent by providing oxygen at a higher pressure.
Okay, sir, thank you. Next question. Is it can be used as an alternative for ventilation? Ventilator.
See, ventilator is one aspect of delivering oxygen and ventilation to the patient. And ventilator is also used to treat a patient. Ventilator is not just meant for ventilating a patient. They can also be used for treating a patient by using various modes we have in the ventilator, like PPAP or pressure support and CPAP, oxygen concentration, so many things. Now, none of these interfaces are supplement to a ventilator per se, but then they can also be used in a setting where we don't have availability of ventilator by, as I said, making use of these ward outlets, which has 15-liter flow. If you have a Y connector to this, you can give 30 liters of flow. Or if you have a high flow meter device with you, you can go up to 60 liters. And this can also be used if ventilator is not available to tide over the crisis. We can use them with this BiPAP machine. We can use with high flow oxygen, or you can use it with the old generation CPAP machines.
Thank you, sir. Let's move on to another question. What is the efficiency of this bubble helmet compared to other?
Well, that's a very difficult question to say. We've been treating COVID-19 patients here, and I have seen that some patients are comfortable with bubble helmet. Some patients are comfortable with high flow oxygen device. Some patients are comfortable with the old generation mask or this. But then by and large, a patient who gets used to a bubble helmet insists that he wants that only because he feels comfortable with it. Ultimately, it is trial and error where you have to use and see whether they are comfortable, because we have to go by many other criteria. If you look at this bubble helmet, there will be some amount of rebreathing with this bubble hoods, because there will be some amount of carbon dioxide buildup. But then we have to take advantage of that situation where, supposing patient has metabolic alkalosis, then he wants his CO2 levels in blood to raise. So then a bubble hood can also be used to treat those patients who have metabolic alkalosis along with respiratory distress. So that way, this has certain advantages, and other things will have other advantage. But then by and large, it is trial and error. We have to, it is individual centric, patient centric.
The next question is, how to disinfect the device used in this method?
Ideally, oxygen bubble hood is single-use device. It comes sterilized, either plasma sterilized, or in a scenario like today, at least it was sterilized. These are single use, and we discard them. But if we have severe shortage of availability of such devices, including the face mask or the snorkeling mask, we can reuse them by thoroughly cleaning them with sodium hypochlorite, and then use some spirit, clean it again, and re-sterilize them. But the staff who are handling these, which have been used in COVID patients, should be extremely careful. They should also be wearing PPEs, and they should take due precaution before we send them to sterilizing department for re-sterilization. But otherwise, I would say these are all single-use medical interfaces.
Sir, is it cost effective?
Yes, a bubble helmet is definitely cost effective because this, once a patient, imagine a patient who has to come to ICU for and he requires oxygen supplementation for 10 days, 12 days. Definitely this is cost effective. With this, whatever NIV that we use, we are trying to avoid intubation. In COVID-19 situation, what we have seen is intubation is easy, but then when we intubate, we as anesthesiologist, the senior most anesthetist has to come, or the senior most intensivist has to come to intubate a patient, because we can't have a failed scenario. And when we intubate a patient, we are looking at the muzzle end of the gun, so much of viral load. So once you intubate, the intubation period remains long, weaning becomes difficult, they go on to tracheostomy, and the re-intubations, failed extubations. So considering all that, I'm sure bubble helmet or other devices are definitely cost effective. We want to reduce intubations, to reduce the mortality. We want to delay intubation as much as possible unless it is really life-saving and it is inevitable.
Is there any age restriction for this device?
No. Today, what bubble helmet I have with me is a bubble helmet that is meant for an adult. But there are bubble helmets available which are meant for pediatric use also. I don't have them. These are what one I have in my hand is for adult use.
Okay, thank you, sir. Another question. Can same pressure can be given when using this helmet instead of BiPAP mask?
Okay. Whenever we use a helmet, supposing I'm using a helmet with the ventilator, I can vary the pressure. I can go to pressure support levels of pressure support. If you see here, I can go to pressure support levels, very high pressure support levels. I can vary the respiratory rate. You can change the inspiratory trigger. When you use this with the, let's say, BiPAP machine, the pressure generated in a BiPAP machine is very low compared to a ventilator. We don't have much control on a BiPAP machine. We have control only on IPAP, EPAP, and we can go maximum up to, I think, 30 centimeters of water with a BiPAP machine. And high flow also, we have certain control on it. But if you use this with a ventilator, definitely we have excellent control on pressure support.
Sir, any investigations to be done during the use of this mask? For example, ABG analysis.
Definitely we have to do ABG. We go by what is called partial pressure oxygen in the blood, what it is when compared to what FiO2, inspired air oxygen concentration that we give. So depending on that, we decide on what to use.
Whether rebreathing of air worsen COVID patients' condition?
Rebreathing of air can worsen a patient's condition, but then you see, whenever you use bubble helmet, the delivery of oxygen is so high, it is under so much of pressure that rebreathing is kept very minimal. And as I said, at some places we want some rebreathing. You don't want rebreathing, we keep on releasing this valve and reduce the rebreathing levels. There will always be rebreathing reservoir-based ventilator patient interfaces when compared to non-reservoir-based interfaces. So you look at those masks, ordinary masks, there is absolutely no breathing unless you're using a rebreathing oxygen face mask. Otherwise, there will be rebreathing, and we have to decide whether that is grossly disadvantage to the patient or whether there are some benefits because of it.
So we all are impressed by your invention. So we have a lot of questions, but so the next question is how to place bubble helmet. Is it like oxygen hood placement, sir?
Okay, hoods are all oxygen hood and bubble helmets the same. No, the hood essentially means this part is called the hood. The bubble helmet is the oxygen hood. If you see here, we make a cut like this and we stretch it with our fingers and just insert it to the patient's neck.
Sir, how long we can use?
Bubble helmet. Well, as I said, we give a trial with any NIV always to a patient for 2 hours, with 1 to 2 hours. With bubble helmet also, we have to give trial, and patient accepts it. His clinical condition improves, doesn't deteriorate. We can continue with bubble helmet. Right now, we have a patient who is on bubble hood from last 10 days. He was shifted to the room. Even in the room, he had drop in saturation. Again, he insisted that please connect me to additional oxygen supply, and we had to use a bubble hood in the room, and he's comfortable with it now. So there is no limit, I would say. But usually, considering present scenario, the patients who require at least 10-12 days of ICU therapy, so we can use bubble hood for as long as we want till the patient recovers.
Okay, so this is the last question. What are the current treatment module in hospital for COVID?
Okay, that is a question which I think if I keep talking about it, it will go on for a very long
It's a
time.
debate question.
Yeah. Now, essentially, what we see today when a patient comes with COVID, first thing that we are worried about is drop in saturation. So we have to take care of the saturation of the patient. Second thing that we worried are the other complications which are caused by COVID-19 virus, like thromboembolisms or increased hyperclots. We have so many acquired infections because of patient being in on ventilator or NIV devices. So many complications. Each one has to be addressed. Patient can have multi-organ failure. Patient go into renal failure. They can develop myocarditis. So everything has to be addressed individually. My talk today, right now, was restricted to oxygen delivery only to the patient and various modes we have for oxygen delivery.
Thank you, sir. We have come up with, sorry, sir, one more question.
Sure.
Sir, due to internet connectivity issues, streaming was facing problem. So pardon us,
Okay.
sir.
Okay.
So thank you, sir. We are
Okay.
very grateful you took the time out of your busy schedule to address our small group. It was
Okay.
really a scholastic session. All the very best for your effort and dedication in the war against COVID-19. Thank you so much, sir.
Thank you once again. Thanks to all the enthusiastic participants, though in small number. And I do hope whatever little knowledge that I've shared enlightens all of you. Thank you very much.
Thank you, sir. So dear participant, kindly stay back. Now I request Mr. Ajit S. Anand to host the event. Thank you. Have a great day.
Thank you, Anusha ma'am. So I'll be presenting the report of the webinar. I'm Mr. Ajit Anand, the convener of webinar, shares the highlights of the webinar. We kicked off the day of the webinar by registering 1,000 plus delegates. We inaugurate the webinar on 28th July 2020 at 10 a.m. Professor Fatima Violet Fernandez welcomed the resource person and the delegates with the delighted words, followed by inaugural address by Professor Pradigna Suhasini, Dean and Principal of Mangala Paramedical Science on behalf of Chairman Dr. Ganapathi P. First session was moderated by Principal, New Mangala College of Nursing, Professor Mary Elizabeth Pinto. She introduced the institution speakers of the webinar. Then she introduced the first session speaker, Dr. Sojan Anthony. He stressed on what is self and how we can overcome stress during this pandemic. The session was really informative. On 29th July 2020 at 11 a.m., the second session was started by Ms. Ann Barnes, Assistant Professor, New Mangala College of Nursing. She introduced Dr. Muhammad Ashil, Executive Director, Social Security Mission, Government of Kerala. He discussed on epidemiological aspects of COVID-19 and its importance. The session was really amazing. On 30th July 2020 at 10 a.m., Mrs. Pooja Ashokan, Assistant Professor, New Mangala College of Nursing, started the session. She welcomed Dr. Sujitra Shenai, Consultant Microbiologist, KMZ Mangalore. She explained in detail the COVID testing, collection of specimen, transport, and storage. It was a fascinating session. On 31st July 2020 at 10 a.m., we started the fourth session on deinstitutionalized nursing care on COVID-19 by Mrs. Daniele Didick. The session was moderated by myself. And the fifth session was followed by a live demonstration of protective gears by Dr. Ganapathi P, Chairman of Mangala Group of Educational Institutions and Mangala Hospital. The session was moderated by Mrs. Anusha, Assistant Professor, New Mangala College of Nursing. The demonstration was very informative and educative. So this is all about the reports, and I thank all the delegates. Now I welcome Mrs. Malati to deliver the vote of thanks.
Good morning, one and all. It is indeed a great pleasure to stand before you on behalf of management and staff of Mangala Group of Educational Institutions to propose vote of thanks on this day. We are highly privileged to have a person with foundation, an idol of knowledge, experience, and inspiration to all of us. He is none other than our beloved chairman, Dr. Ganapathi P, who was also one of the resource person of this webinar. Thank you, sir, for sharing your innovative information with us. We are grateful to our beloved Vice Chairman, Dr. Anita G. Bhatt, for her support and motivation in organizing this webinar. We appreciate and thank Sri Rajesh Mali, Secretary, Mangala Group of Educational Institution, and Dr. Dharmaraj, Student Welfare Officer, for their valuable contribution in the success of this webinar. A special thanks to Professor Pratigna Suhasini, Dean, Mangala Group of Educational Institution, for her guidance and support. We would like to thank Professor Mary Elizabeth Pinto, Principal, New Mangala College of Nursing and Mangala School of Nursing, for making this webinar a great success. We express our gratitude to Dr. Sojan Anthony, Assistant Professor, NIMHANS Bengaluru, for being a resource person in this webinar. Thank you, sir, for your exemplary session. We wish to express our profound gratitude to Dr. Mohammad Ashil, Executive Director, Social Security Mission, Government of Kerala, who agreed to be one of the resource person in spite of his busy schedule. Thank you, sir, for enriching our knowledge. We are also delighted to have Dr. Suchitra Shenoy, Consultant Microbiologist, Kasturba Medical College, Mangaluru, for enriching our knowledge on COVID testing. We must mention our deep sense of appreciation to Miss Danielle Didick, a nurse educator from Canada, who agreed to be one of the resource person in spite of her busy commitment. Thank you, Miss Danielle, for delivering an inspirational talk. A big salute to our organizing secretary, Mr. Ajit S. Anand, who worked hard behind the success of this webinar. We would also like to express our profound gratitude to all the delegates who participated in this webinar, without whom this webinar would not have been a great success. We express our sincere thanks to Mr. Vijesh Kumar, PRO, for every technical help. A sincere gratitude to Mrs. Shilpa and Mr. Praveen Udupa for arranging the entire platform for our webinar series. Thank you, ma'am. Thank you, sir. We thank Mr. Niju Raj and Mr. Reju Raj for their contribution in the success of this webinar. Our special thanks to all the teaching and non-teaching staff of Mangala Group of Educational Institution. Thank you, one and all.
Dear participant, upon the submission of your feedback form, you can download the certificate. Thank you. Stay home, be safe.
Thank you. Thank you all.
Thank you, ma'am.